Sophie and are you nearly ready to?
Yeah.
So it's time to start sort of wrapping up that conversation. And just to remind you that each group will be asking to present a particular either scenario or challenge or issue to the panel for some discussion, as well as perhaps some. So, can everyone hear okay from where you are? Yep. Probably don't need to reintroduce the panel, do we? No. Everyone, I feel like we should be doing formal invitation. So really what I'll be doing is facilitating and making sure that we get the most out of the combined knowledge sitting up the front here, but also to get the most out of all of you, because I think we've got a fairly even spread of knowledge right through the entire room and across all of our disciplines and areas of practice, because I think I'm looking, we've got representation from pretty much all of the areas that allied health working across Bendigo Health and who end up touching on cognition. So while the panel is sitting up the front and are very much experienced in this field, I think we've got a fairly equal amount of experience sitting behind the tables as well. So while the panel are there, I think a two-way conversation will be of most value to us. So rather than wait for a hand up, I'm just going to go here because you're closest to me. Do you have a particular challenge that we might be able to present to the panel?
Yeah, so one of the issues that we identified was working with patients that have a lack of insight into their cognitive deficits. And then the challenges that come with that around the therapists see it as a really important area that should be worked on during therapy. But the difficulty if the patient doesn't identify that as an issue, how do you develop a client-centred care plan around that in treating that issue?
Because they don't have insight into
it. Yeah.
Anyone feel they can comment on that first? Around making, so very much about how do you do a client-centred or patient-centred plan?
Yeah, if they don't see that as an issue or an area that they feel they need to work on.
Did this come up in your practice?
Oh, I think it is really difficult. I think you can try lots of different tacks to help them to gain some insight, but the bottom line is if they can't, then they can't. And then you have to try and work with family really around that instead. But it's interesting that often we don't tell people, I suppose, or explain it enough to people, perhaps, so that they can try and understand a little bit more about the issues. And again, you know, you've got to also be careful about, well, how much do you need to actually do anything anyway, and who's got the problem? Do we actually
we talked about capacity and
do we need to intervene anyway in someone else's life? Is it really necessary to do in the first place? Because they still may be able to have a good quality of life and support around them without being too intrusive on
I guess the issue becomes when there are the safety issues identified. But in terms of making client-centred goals around those, that I think it's really difficult to marry those things up, and in some cases, where there are safety-related issues and a lack of insight, they might not get away to line those things up and to make them patient-centred, which we try to do. I do find that a lot of people that I am referred to, I'm in outpatients, a lot of people that are referred that have a lack of insight while they're on the ward, it has improved a lot by the time I see them, which is probably has a lot to do with the length of time since the brain injury, but probably also has a bit to do with the feedback they've just got from living at home. They've seen the deficits that are occurring for them in the natural setting, so and come up with problems. So it probably is something that when you are on inpatient rehab or more acute settings that is really difficult, and idea. So I reckon what sometimes works is to engage them in something that they are willing to work on. It's usually physio. Because it's something very concrete, and so yeah, they'll go and do their physio, but OT and speech, forget it. And so it's kind of like, I think, engaging the client in that, and then sneakily bringing in other activities that might incorporate cognition as well. And so if they're engaged, they're then more likely to come on board and try an activity, and trying to use activities that they can see are relevant. So when I was working on inpatients, I did so much cooking, because that was actually a functional thing. You could do a lot around cognition with that, and it's also standing balance and all those things. And so they'd often come on board with that. And as Jo said, I think sometimes time, so they might not take it on board now, but if you're engaged with the client and haven't got them offside, when things don't go well down the track, at least you're kind of there and they trust you to sort of help them to deal with that. So that's just sort of one idea.
It's a valuable comment about a transdisciplinary approach, really, isn't it?
Yeah.
So who will they work with?
Yeah, that's right.
And what can they gather in the background then to incorporate into a therapy plan? So it might address a few other things on the side. Tracy, did you want to comment on that at all?
Said it all beautifully.
Can I just say one more? I think the safety aspect is really important. But over the years, I've probably got less and less worried about that. I mean, it's something that I used to worry about much more.
Yeah.
But there are still some people that you get to a certain point when you lose sleep and you start to think, no, got to do something about this.
Yeah.
But I think more and more I've thought that we've needed to intervene less and less as time's gone on, because despite the fact that we often have trepidation in sending someone home from the rehab ward, for instance, the thought that they weren't going to manage, well, they do in their own way a lot of the time. And so more and more you do think, well, perhaps we can just put some subtle monitoring in or something and just see how they go.
Often we're aiming for perfect.
Yeah.
When okay is okay.
Yeah.
That's valuable.
I've had a shower for 2 years and you think, well, they're going to die.
I'm not going to sit next to you on the bus.
That's a high contraction
Thank you. All right, over the back.
Change in strategy when you're trying to get that type of person engaged.
Yeah.
I don't know if you have any comments about that.
Yeah. So engaging someone in therapy when there's either taught, denial,
Yeah. I
lack
guess
of
we've had kind of
insight.
insights if you want to talk more
Is
about
that
that.
denial?
Usually there's something to say. I think sometimes you can't do that. Sometimes I think it's time, and if it doesn't matter that you wait a bit, like we have that a lot in memory clinic, that people will say, there's no problem with my memory, I don't need that referral and decline it, but what we make sure is the door's open. So we say, okay, that's okay, but if you need us down the track, this is clearly what you need to do, and also make sure the GP knows, so that if time isn't going to be detrimental, denial, some people come to terms with things at different times, so that's
I was just going to add too, it's probably a little bit separate to what you're saying, but I think having worked sort of across the continuum, you sort of denial and hope sort of clash a little bit too, because you have often we're trying to goal set with people and set realistic goals, yet people are hopeful and they're shooting for the stars, and it can be interpreted as denial, but I think there's a role there for hope and hope that they're going to get better, and sometimes people really surprise you and they do better than you ever expect, so finding that fine line of accepting where they are at the moment, engaging in whatever's meaningful, and giving them room to have hope for better things in the future is, can be a strength-based approach, so it can be a nice way to work with that group of people.
I wanted to add from an early comment that you made around working with the family and being told, no, you're not to work with my family. How do you actually see the family as one of your clients when you've got someone in your service? At what point, where is the line that you think, well, actually you are someone that I'm providing services to as well?
I mean, if the person's saying they don't want you.
I don't work in an inpatient setting again, and I think often I see people in isolation. I do always try to get background history from an informant, and I would rarely just have someone say, I don't want you contacting my family and not talk about that a fair bit further. So trying to establish the reasons for that. I think there could be valid reasons as well, but there could be cognitive reasons. In any case, I think possibly the best that you can do at that point in time is give education that is appropriate for the person's ability to take it on. Flag some things that the person might want to look at, put it in writing, say you may want to show your family member at some point in time, or you might want to refer to this, but I'd want someone else to be, such as the GP, to also be aware if there's no family that is able to take on, to pass information on to. It would be probably the GP that I would be passing that on to, so that there is some monitoring, or any other service that's available.
Yeah, I guess it gets back to what do they understand about it all and what their issues are. And if they really are very much lacking in capacity, then, you know, I think as a doctor, you make a call that this person really can't consent to the treatment that they might need, or whatever that's on offer. And in those circumstances, I would actually just stop contact with them, because I think that the appropriate family member, so I wouldn't think that they've really been able to consent or not consent, I guess. So it gets back to what their level of understanding is, and obviously if you tease things out a little bit more first, often you can work your way through it, can't you? But there are
rare
those
that you get a no that sticks. And not through any methods of saying I must do this. It's more trying to explain.
Understand strategies and help preserve our relationship, to understand cognitive impairment. Even if, you know, the family's not consenting to that specific information, you can obviously give them general information about cognitive impairment, and I guess build on that from them and try and keep them as a unit. That's going to be an option.
you often have, you know, there's a lot of baggage that people carry for a long time, and there's reasons why they might not get on, and you have to also tread a little bit carefully about that. I mean, in situations of, you know, past violence or abuse or something that may not be known about, and that might be why someone's not keen to be involved in a family member's care. So you have to be fairly sensitive to those potential issues as well when you're trying to decide who is appropriate to talk to.
All right, group over the back.
We had obviously some of the same information that these guys were looking at. We looked at insight, we looked at families, but the one that we chose to present to the panel is about time constraints. We all know we all have time constraints no matter what area you're working, but we're also talking a little bit about wait lists for services, and I think the one that came to mind was obviously Joe's service, neuropsych, and thought we'd pose that to the panel about some strategies for if there is a long wait, or is there any advice that you can provide us?
So you've got someone who's in your service right now, can't get a neuropsych service, that's definite.
Or other wait lists as well, I guess, clinical-related wait lists as well, programs.
What could we do? Do you want to answer that one first, Joe?
Well, I guess I can talk about the neuropsych wait list, but I am not hugely aware of how often this is coming up on the wards. Susan is our senior neuropsych, so I would say that she would have possibly a little bit more information, a bit more to say on that, so I apologise for not having all the information. What I would say is there are potentially other avenues if you do need a timely assessment. So I do know that the inpatient rehab ward, and there have been really pressing issues to do with discharge. Then there have, on those cases, outside services have been procured, so private neuropsychs, and there are private neuropsychs that come up and don't have wait lists, or can be seen within a couple of weeks. So that, I guess, is one option while we don't have any funding to see people while they're on the ward. In terms of wait lists after discharge, we have high and low priority wait lists. So they're the weight should possibly be at a few months for our high priority. And I think in that time, as if the person is involved in other rehabits, particularly with OTs, it can be really good to have that input in the first instance when the person is first discharged. And it can provide us with a lot more information and allow the person to settle a bit before and come to our sessions more aware of what their issues are so that you can have some input. But yeah, of course they're ways.
Can I ask what sort of strategies you're describing would be useful?
Well, I guess that's sort of the right information that, yeah, if they're coming to your service and we know there's a wait list for that service, is there things that we could be doing in the meantime as therapists as a multidisciplinary approach, which is sort of what you were touching on, that, you know, I know you gave an example of OT being that you'd be doing some of these cognitive screening tools and looking at compensatory strategies or whatever it may be that we're doing with a particular patient or client. Is there anything else that we potentially could be doing or that you've come across or hurdles, etc.?
Well, one thing I didn't mention, but Tracy mentioned a fair bit with her presentation, is even documenting or communicating what issues come up. I presented all about executive function, but didn't really tell you anything about how we assess it, and we're assessing in a one-on-one environment where you're really providing so much support that you don't see these executive functioning problems. So documenting can be really helpful for us, but for the client themselves, I think it comes down to what the pressing issues are. Do you have particular issues that often come up? Is it around sort of safety? Okay, return to work. That's probably a big one.
Yeah, and a lot of it is always determining capacity on this.
So determining capacity.
Yeah.
Yeah, and that's one of those cases where I've been thinking about other services. And there are also services for ABI clients, for places like the ABI Behaviour Consultancy, or for compensable clients that diverge. And they have neuropsychs, they do assessments, but then they also put in place behaviour management strategies. So that could be one way. Unfortunately, I don't think there is a good way for us to be able to assist with discharge at
How
this
would
point in
you,
time.
if someone knows that they've been referred to neuropsych and has some understanding of what the assessment will involve, what about the angst in that waiting time to be assessed? And that anxiety in itself could actually be exacerbating some of their underlying cognitive symptoms. So, you know, what's the best thing you can say to someone who has been put on a wait list?
Does anyone understand on that? A response to that? What do you say? Have you come up against that situation?
Good question.
Maybe the tail. The family.
In fact, if they keep remembering about it, it's actually a good thing for the neuropsychologist to know that there's some other information and they have got capacity to remember.
I don't know how often that occurs, that a person themselves is wanting it really quickly. In fact, a lot of the angst is actually that coming.
Yeah. So clinician angst.
What should I be doing right now? I know I can't get the neuropsych input. What could I be doing? What do I need to take into account?
It depends. So I guess one thing to think about that I think might need more immediate input can be things around return to work. Often a person has finite amounts of sick leave. Often I see people who run their own business and just say, I have no choice. And you talk to them and you see their level of impairment and their level of fatigue a year later, and you just think, how on earth did they return within a matter of weeks? And they probably potentially were making poor decisions. So I think when there's return to work and cognitive issues, it's really potentially important to get OTs on board. And
I was going to say that sometimes even doing a screening assessment, I know it's not in depth, but you can identify areas of possible concern and then work with the client on strategies for that particular thing. So it depends on what's riding on it. And sometimes that can be enough if someone's got something to take away and work on and they can see some improvement. And you're working towards their goal of return to work. Because sometimes you can actually come up with some pretty good and relevant strategies that helps them. It depends if there's something legal riding on the neuropsych, or that's when you're more likely to get angst. But normally people are happy to work I found have to work with us on all of that, and can actually provide some even good strategies for return to work and work with the employment provider and all that. Without the neuropsych, and the neuropsych just provides some additional input at that point. But if we've got something, if it's, but there's not that, I don't know if there's that many things that we're actually riding on the neuropsych.
I think that's a good bottom line. I think that's suggesting that if there's something critical, riding on it.
And really, I guess we are mostly an assessment service, and you guys do have really good strategies. So having faith in your own strategies and ability to implement cognitive strategies. Most of our recommendations you're all absolutely aware of. It's potentially just a matter of tweaking them according to what we're seeing coming through on the testing and saying all these strategies of structure and writing things down are great, but we might be able to tweak them a little bit based on the presenting problems that come through when we do the assessment. So I think, just making sure that, I think patient education is a huge thing, making sure the referral's gone through from LTD if need be.
And finding strategies that suits the person's way of thinking, and whether it's electronic or whether it's diary, like just really trying to work with them and make it very specific.
Does that come out of the CADMS report at all?
No, CADMS, no, that's more for my neuro, when I'm working neuro.
Oh, okay.
CADMS, the strategies, that more comes out in the when we do an information session for families and clients, and Alzheimer's Australia tend to follow up more specific strategies. But we don't focus on strategies in memory clinics.
Yeah, I just wanted, because I think I've had a client that had been with the op and then came back and sort of said, I think they told us some things, and then I didn't know if I should but then they got referred to Alzheimer's and they took care of it. So I was kind of like, I don't know if I should follow up and see if there's anything in particular you recommended that I should continue with in the home. But I think, DD that's when.
And that's what they do. And we do give them a folder with all information and all that. But.
All right, we've got a few minutes left. Has this group got a particular challenge to present to was it already covered? I think the conversations were very similar. I think the same sort of issues do crop up around this area. All right, in the last few minutes then, we go backwards then from you guys. Have you got some particular strategies that worked well, or examples of something that would be great to share with the group?
We had to come talk about this week about geriatrician. I've done that before. Ring them.
I think that's just a positive comment. And say that's a bit like a few of you. Probably the answer there. The group down the back.
Donna's taken over today with burning OT.
Yeah.
We talked about a couple of the probably slightly different things we talked about was the use of allied health assistants to reinforce our strategies has worked really well. Utilising community services and particularly focusing on, and I think allied health do it very well, is our communication between our services as well. We should really look at how good that is and be proud of how well we communicate between our services.
We talked about training communication partners, both like within health professionals who work with the patient with cognitive impairment and their families and friends as well. So what Tracy touched on before.
So training other clinicians.
Yes.
But also the family.
Yeah.
Areas of people that
Yeah, strategies for how best to communicate with the patient.
And I'm sure with their plans potentially to do a bit more formal conversation partner training at another allied health session at the next one in July, possibly as one of the concurrent sessions. Right. Thank you. And this group here?
One of our strategies was using the team, so in terms of identifying, liaising with the other team members, whether the patient's been presenting in terms of behaviours or ability to follow instructions, whether they've been presenting in a different way with other therapists for a range of reasons, as well as using the team to make sure we have a consistent approach in implementing the strategies that we are using. And Catherine had a good example as well, for example with Joe's extensive waitlist for neuropsych. Catherine would do a thorough assessment in OT and then liaise with Jo and see if there's anything additional she could implement while the patient or the client was waiting for neuropsych input.
And I'm going to throw to you, Nikki, because I know you did a lot of the groundwork with OT guideline and looked at a lot of this, sort of what was discipline specific and how you interact across teams and disciplines. I think we've got any other comments with that one.
Not specifically, but yeah, I would agree that the communication within the team is absolutely essential, and as Jo was saying, just those little bits of information that you think, that's not quite right, making sure that gets documented so that it builds a bit of a history for whatever it is down the track and helps with that diagnosis aspect.
Fantastic. We have 4 minutes left, and being allied health, it really matters to us at one time. First of all, if I can thank the panel, and I won't finish up, I'll probably hand back to you, Jo, but thank you to the panel for being prepared to just take whatever we prepared to throw at you just then. I think that went really well. And thank you, Fiona, for your fast. I think this will be the best way of gathering information we've probably ever done. I don't know, Jo, do you have feedback forms and things like that?
Yeah, so everyone who is here today, you'll get an email for a link to a survey monkey. Please provide us with the feedback. It's critical to the future planning of these events. So we'll hopefully get the information out on the next in-service very soon. And try to get a bigger venue.